In addition to that, we've talked about the CD30, again, Brentuximab Vedotin. I was wondering if we have an elderly patient, say with comorbidities, and they're not good candidates, say, for standard, what we just discussed upfront, chemotherapy, say ABVD, would there be any other considerations? And maybe we'll go with you, Anas. What do you think is out there, maybe being presented here at ASH, or what the future may hold for us with those patients?
So it depends how you define elderly. I mean, you really, again, have to take it case by case, see who could potentially tolerate chemotherapy, because right now chemotherapy is the only treatment that have track record of treating patients. True that the cure rate is lower in older patients than younger patients, but that's the only thing that we have of track record. Now, if patient is not candidate for chemotherapy or refuses chemotherapy or have multiple comorbidities, then you can think of alternative approaches. There's very interesting data presented this meeting using Brentuximab single agent on a clinical trial as a single modality for these patients, and it showed really intriguing results, 80-something% response rate and about 60% CR rate. Small number of patients, I think 11 or 15 patients treated, so also you need to look at the long-term follow-up. Sure. But if this data hold, it may open the door for alternative treatment strategies.
Very interesting. What would you do in a patient, though, say that not just they're elderly, but they have cardiotoxicity, so the patient has cardiomyopathy. So is there a different approach to use for that particular patient that would not be a good candidate for anthracycline-based treatment?
Yeah, there are several non-anthracycline-based regimens that have been used. My default is to use CVPP, or also called CMAP, off clinical trials. That's what I would use usually.
Anybody else have any?
We also similarly use that regimen. There's a CEPP with etoposide and procarbazine regimen that is used. And then I would probably, in the Stanford 5 regimen, you know, in the studies with ABVD, those were powered to show a superiority to Stanford 5, and that's half the doxorubicin that we see in ABVD. So in someone who doesn't have, who can't get no anthracycline, but you're concerned about that, that is an alternate curative regimen that uses a lot less anthracycline.
Any comments?
I think, Myron, we discussed before we started this panel that many of us would use pegylated doxorubicin, a combination of pegylated doxorubicin. That's my practice. This regimen, GVD, is pretty well tolerated and potentially avoids significant cardiac toxicity, and in many patients can be better tolerated and has a proven track record.
Any comments, Laura?
No, I would agree with the panel.
Okay. I'd say next, with respect to the use of Brentuximab Vedotin, would you use it to get patients, for example, the way that it's approved, for example, in Hodgkin lymphoma, is in patients, you know, after, say, 2 prior therapies or after autologous stem cell transplant. What about the patient that, you know, you can't get to transplant, they've had multiple treatments? Would you utilize that actually, how would you utilize it, say, pre-transplant or post-transplant? I think it's some interesting discussion with respect to, maybe we'll stop actually with Andre. What if you had a patient who you're treating and basically they have relapsed, you gave them salvage treatment, whether it's ICE or DAP, and they're still positive on PET scan. They're not progressed, they actually responded, but do you feel there might be any value in continuing therapy before, say, going to autologous stem cell transplant?
It's a very good question, Myron, and while the answer is not definitive, I find our institution more and more using Brentuximab Vedotin in driving patients to PET negative remission. There is certainly data that patients going into the high dose therapy with PET positive disease might have less favorable outcomes after high dose therapy, and trying to get them into metabolic remission could be beneficial. So it is only biologically and clinically logical to try and shut off that PET positivity, and we end up using Brentuximab Vedotin in situations where 2 or 3 cycles of ICE still leave uptake on the PET scan. I don't know, I'm curious what panel.
No, I was just going to ask you about that. When you've used it in that setting for some residual positive, what's your experience with the kinetics of becoming PET negative? Do they become PET negative after 1 or 2 doses with a quick PET, or do you have to wait a little longer? You know, what's sort of the timing of the PET response?
Yeah, again, this is really personal experience, anecdotes, and if I have to quickly pull it out of my head, roughly 2/3 of the patients were able to achieve PET negativity, and typically would go for 2 cycles and do another study.
Okay. Any other comments on this? I guess what we should discuss, do we have any problems, the panel, with respect to either the dosing and or schedule, the use of Brentuximab Vedotin in the patients that you're treating with whatever patient you're giving Brentuximab Vedotin to, and how do you handle the dosing and schedule? We'll start with Steve.
Pretty much we use the standard dosing schedule. It's every 3 weeks, 1.8 milligrams per kilogram, reduced for primarily neuropathy if we reduce dose or hold doses. Haven't had major problems with that.
Let me ask Anas, how about yourself?
So same thing. As you know, there was 2 phase 1 trials, looks at 2 different dosing schedules with Brentuximab as single agent. One that was weekly times 3 with 1 week off, and one that once a week, every 3 weeks. Both had almost similar efficacy. Of course, it's more convenient to give it once every 3 weeks than the weekly schedule. But there are trials looking at both schedules for different reasons. For example, the one that we do at Memorial in pre-transplant setting, you want to give many doses in a short period of time before transplant. Makes sense because you're not planning for the prolonged treatment. But if you are planning for prolonged treatment, I think it makes more sense to go with the once every 3 weeks.
But let me ask you a question. So say in the practicing community oncologist, you have a patient on therapy, they're responding, they've already failed an auto, not candidates, say for allo, there's no other protocols that they're open for at that point. Would you consider stopping the drug, or how low would you go down? I'm just curious, do you have any feel for, can you drop it down to 1.2 or lower than that and continue therapy, or stop it completely?
Post-autologous transplant?
Post-auto transplant, say a patient that's responding nicely to therapy.
Right, so that's on-label treatment, right? So you start with 1.8 milligram per kilogram once every 3 weeks.
Right.
If you're achieving a partial remission, I think then you should think of continuing treatment until you explore the option of allotransplant. Right. And then you have to gauge toxicity and benefits. So if there's neurotoxicity, for example, it would be good to do either dose interruptions or reductions down to 1.2 milligram per kilogram, down to 0.8 milligram per gram if you need to.
If you never go down less than 0.8 at this point, right?
Yeah, no.
If
you go, if you achieve a CR, that's a different story. And I think even though the label allow you to go until progression, I think most of us then will make a decision about when do you want to stop. I usually tend to stop after 8 cycles and see how it goes.
Very good.